Hello, everybody. Welcome back again. And my name is Osama Shawki. I'm professor of gynecology in Cairo University, and I'm pleased to join you today. And I'd like to welcome all of you to my home, the uterine cavity. This is the place where each and every one of you enjoyed full board accommodation for 9 months. The uterus. So, hysteroscopy became one of the most exciting endoscopic technique in the past 2 decades. But the most frustrating problem for all colleagues that we cannot see well. The view is blurred, like what you see like this. The visibility is not convenient. And many colleagues feel frustration that hysteroscopy view looks like this image, the Japanese flag, just a rounded red circle on the white background monitor. These kinds of views are very frustrating. Especially you don't see a panoramic view, you cannot see where is left, where is right, and it's difficult to perform a procedure with this visibility. It should not be like this. It should be different. It should be like that. That's the way it should be. You should have a beautiful panoramic view for the cavity with identification of both ostia, fundus, anterior wall, and you should enter the cavity under vision like this. You can see the polyp, you can see the septum with a very clear view. I hope to be with you and show you these things lively. And the myoma. Okay, so let me bring you to what is the most important point for visibility. It is distension. Look at this balloon. Okay. Without pneumoperitoneum, you cannot do laparoscopy. And without proper distension of the uterine cavity by the fluid, you will not see well. We have to agree that in hysteroscopy, there is a lot of challenges to achieve distension. Sorry, it is reversed because of leakage. In laparoscopy, there is no leakage of carbon dioxide that can affect visibility or can lead to deflation and collapse of the belly. But in hysteroscopy, you have leakage from the cervix, from the fallopian tube. So there are 2 important issues to keep visibility: the inflow and the outflow. There should be a good balance between the amount of inflow, volume, and pressure to stretch the cavity and the desired outflow to clear the debris. Sometimes if you have low volume, low pressure, the cavity is collapsed, you cannot see well. And if the outflow is open maximally, you collapse the cavity and still you cannot see well. So such view, okay, this is uterine cavity in a case of myoma resection, and there is a lot of bleeding. We have to agree on an important fact. Listen to me. Let's talk logic. The arterial blood pressure is 120/80, which is almost mean arterial pressure is 100. This is the pressure inside the blood vessels. So when you cut into the myoma or you cut into the septum and you open these blood vessels, if the intrauterine pressure is less than the 100 of the intravascular pressure, so the blood will flow from the vessels into the cavity and you will have this terrible view. Look at this. This is somebody trying to do myoma resection. This is the resection loop, and there is a bleed. It's not a terrible bleeding, but this makes the visibility very bad, and there is collapse of the cavity. When you compare to this with a proper pressure, yes, that's the way I like it. Okay. So you have to maintain and sustain an optimum intrauterine pressure to be able to complete intrauterine surgery. Listen, my friends, let me explain something because it's a very sensitive, very political issue. Okay. For mainstream hysteroscopy. What does it mean, mainstream hysteroscopy? Which is an office procedures without anesthesia, or simple procedures like taking out a polyp, missed IUCD, diagnostic or endometrial biopsy, or little adhesions. This is I call mainstream hysteroscopy, which is everybody should be able to do. In that cases, you don't need a high intrauterine pressure. Just open the cavity by separating the walls to see well and catch your pathology or take your biopsy. But for intrauterine surgery, people still call it hysteroscopy for the myoma resection. No. I like, or I love, or I desire to change the terms, to change the definition. It is no more hysteroscopy. The large myoma, the large septum, the terrible intrauterine adhesions and Asherman syndrome, this is intrauterine surgery. It requires different equipment, different distension fluid, different pressure, and different complications. And the skills are also. Okay, let me share with you some of the procedures like congenital uterine anomalies. When you see these Bugs Bunny ears in the hysterography, you get confused. Is it a septum or is it a bicornuate? Listen to my rule. If the angle between both corneas is 90 degrees or less, this is 100% septum. If the angle is more than 90 degrees, then it's difficult to tell. So this is 100% a septum. This could be a uterine septum. It could be a bicornuate uterus. You cannot tell. So we have to add another investigation, which is 3D ultrasound. In this 3D ultrasound, you can see how, well, both corneas and in between, both corneas and in between, there is the shadow of tissue. This triangle is the uterine septum. If you inject water during 3D hysterography, 3D ultrasound, you can have sonohysterography with a beautiful view for a uterine septum. So this is another 3D view. Both you can see here, this endometrial line, the other endometrial line, and in between is black color. So this is a bicornuate uterus. Okay, another example, this is also different types of uterine septum. Here the septum reaches midway between the fundus and internal os. You can call it subseptate or short septum, incomplete septum. Here the septum reaches to the level of the internal os, so this is a complete septum. Here is a very rare anomaly, which is uterine, cervical, and vaginal septum as well. So 3D ultrasound is the most important diagnostic tool. So the technique that I like to do, which is I call it with my name, the Shawki technique, is using the resectoscope and start cutting the septum from below up, moving from side to side. And you should keep the tubal ostium. Here is the tubal ostium. This is your landmark to know the level of the electrode. This is the electrode, this is the tubal ostium, and the septum is stretched. How to achieve this stretch of the septum? Definitely by proper intrauterine distension. Forget about the word pressure, call it intrauterine distension, which depends on the inflow, outflow. By the way, let me tell you, one of the very big secrets of a good hysteroscopist is not how you move the equipment or you move the tools at all. It is your ability. It is your ability to calibrate and adjust the inflow and outflow. And remember that in laparoscopic surgery, it is not your job to do this. Somebody else from the nursing staff will adjust the pneumoperitoneum machine to pressure 15, and then you work all the time. Okay, rarely you open to decompress smoke during work, but you don't need to play much with the inflow and outflow. But in hysteroscopic surgery, it is your job. And this is the secret of the good hysteroscopist. And then once you achieve this view, you start cutting into the septum by moving from side to side. And again, this is the tubal ostium and this is the electrode moving from side to side. How to do it? I have to stand next to you and show it. And this is the final view when you stop, when both tubal ostium are at the same level and you have a straight line. Let me show it to you. That's a very broad septum. Moving from side to side. Moving from side to side, keeping the ostium as your landmark. Okay, the tubal ostium should be your landmark to know the direction of the electrode until you reach the fundus and you check my video that I'm always looking and checking the tubal ostium. Okay, tubal ostium, because this is my landmark to know when to stop. And then you decide this is the end of the procedure. You have a big white area, which is the septum bed. And 2 months later, we do hysteroscopy. You have a beautiful cavity and total reconstruction. I can speak about the septum for 2 hours, but they give me only 20 minutes. So, right, septum is not just cut and forget. Please don't underestimate the skills needed for septum surgery. Listen, my friends, the procedure is called metroplasty. It is a plastic procedure. So, is there an other way to do it? Yes, you can do it by the scissors, like this. Check the tubal ostium. Rotate the camera left and right. And then cut exactly in the middle. Okay, so probably everybody is asking why there is no bleeding here. Why there is no bleeding, okay? Despite there is no electrocautery. This is thanks to the proper intrauterine pressure, which keep the tissue stretched and avoid bleeding, okay? You keep cutting, and rotate. I will show it to you, okay? If this is the telescope, nice. I have a good idea to teach you now, all right? So, this is the hysteroscope. You hold the hysteroscope camera in your hand, and the other hand is holding the scissor. If you want to look at the left and right, the classic teaching that everybody tells you, hold the light cable and rotate the light cable. But how can you do this when you have a hand holding the scissors? So you rotate the whole camera like this. When you rotate the camera like this, you can check the cornea or the lateral wall, and the scissor in the other hand. So it's a combined rotation of the both left and right hand to access the septum in both sides until procedure is finished. Like this. This is the final view. Septum is totally released. Sometimes fine cuts to reach perfection, and a panoramic view will tell that both tubal ostia are at the same line and no more. This is the final view, okay? And this is healing after the septum does not require any additional post-operative treatment. There is no need for a balloon or IUCD or estrogen progesterone. This is second look after 1 month, only 1 month. You can see the septal white area start to be covered by pinkish islands. You see that? Pinkish islands here, all right? And then after 3 cycles, complete healing. Complete healing. Before and after. Again, I know it is exciting. Everybody wants to do it. It looks easy. And by the way, when things looks very easy, actually it's not like that. Jude, this is a very important advice. When things looks very easy for a beginner, when you watch other doing it and you think it's very easy, it actually hides a lot of skills in the hand that you have to learn. I give you an example. Go and watch your children with the PlayStation. When they are sitting with the PlayStation and doing Need for Speed car race, you think it's easy. Try to catch the controls and do the same. So be careful. Nothing is impossible, but nothing is easy as well. So I will finish, because they give me only 20 minutes, with fibroids. Well, the FIGO classification for the fibroids put them into 7 categories. Type 0, when the whole myoma bulging into the uterine cavity and attached by a narrow pedicle. Type 1, when more than 50% of the myoma bulging into the cavity and less intramyometrial. Type 2, when the myoma is more deep, more than 50% deep into the myometrium and less bulging into the cavity. Type 3 and type 4, both of them are intramural, but type 3 is intramural touching endometrium, type 4 intramural touching the serosa. When it starts to migrate outside the surface of the serosa is type 5. More than 50% bulge is type 6. And if it is pedunculated, it is type 7, which is equivalent to type 0, but this is pedunculated subserous, this is submucous. Myoma resection requires certain preparation and certain situation. It is not like laparoscopic myomectomy. In laparoscopic myomectomy, whatever the myoma is big, you can still insufflate the belly more, and you can find the space left and right to move around and to do your surgical steps. But for the submucous fibroid, if the myoma is a little bit big, there is no space left and right. The uterine walls are already touching the myoma. So here, this also highlight again the value, the need, the demand for achieving proper. I'm not saying high, because when you say high pressure, people call me crazy and they attack me, okay? I'm saying the proper pressure just to separate the walls. How much of this? Impossible to tell, because there is a leakage from the cervix and there is a variation in the size of the uterus. So it's not like laparoscopy, you can say a pressure of 15 is enough to insufflate the belly. Here it's very variable because of the variables in the leakage and in the size of the uterus. And one more important thing that every hysteroscopist should know, that the pressure setting shown on the machine or in the pump is absolutely not the same pressure inside the cavity. So for laparoscopy, when the machine says 15, the intra-abdominal pressure is 15. But in hysteroscopy, if the machine says 120, inside the uterus could be hardly 60 or 70, because the pressure coming from the machine 120, but the uterus is leaking a lot, so you cannot actually measure inside. And there is no pump in the market, whatever the technology, can tell the actual intrauterine pressure. So, Osama, we are confused. How could we know the pressure inside? Only one thing can tell you. Only one thing. If you start cut into a myoma and you find bleeding happening, it's not terrible bleeding, but some blood is leaking. So you are definitely the intrauterine pressure less than the arterial blood pressure. You are less than 100, definitely. Exactly how much I cannot tell, all right? If you raise the machine pressure, say machine is showing now 280, and the blood starts to disappear and the field is clear, so this means inside the uterus you are above the 100 and you are tamponating the vessel. And at that moment, the absorption of fluid is at risk. And fluid overload can happen if you continue for a high time. So you have to raise the pump pressure gradually until you tamponate and stop the bleeding while operating. This is the point. If you want me to cover the issue of fluid overload and the terrible TUR syndrome and electrolyte imbalance, blah, blah, which is, in my opinion, the one and only complication is hysteroscopy. Forget about any other complication. Perforation is not really a complication. There is no bleeding in hysteroscopy. The only complication in hysteroscopy is fluid overload. There is never a report of any case died of bleeding in hysteroscopy. They die from the water, not from the bleeding. So anyway, 3 important parameters you have to put in your mind for the fluid overload. Number one, and the most important, the duration of the procedure. The longer the duration, the higher the chance of fluid overload. Number 2, the volume of fluid. Don't tell me that I'm working with a low pressure and you consumed 11 bottles of fluid. Oh, this is absolutely ridiculous. So the duration, the volume, and lastly is the pressure. Definitely, if you're working with a high pressure for long duration, you're consuming volume of fluid, which leads to death. If you are working with a very low pressure for a long duration and many bottles of fluid, the patient will die as well. In my humble opinion, you have to reach a certain level of expertise. Again, intrauterine surgery is not hysteroscopy, okay? And it's not 80% of the work is simple, but for the large myoma, it's not it's an intrauterine surgery. You have to achieve a high pressure to see well, and then you start to cut into the myoma or in the septum. If you see well, and visibility is okay, and equipment is well, you should finish maximum in 15 minutes. Actually, I don't want to be show off, and I say the septum in the average good hand can finish in 5 to 8 minutes. So there is no chance for fluid overload. Whatever high pressure it is, the volume of fluid consumed in this 5 to 6 minutes is very low. But if you're not seeing well, you're consuming time. Okay. So create the space by the good pressure and start to cut into the myoma, and don't keep going in and out, because every time you go out, the cavity will collapse. So the chips you have cut, try to push them to one side. How to push? There is no retractor. Use the fluid pressure, direct the telescope like this to push the debris to one side and keep on until you finish. Okay? So let me show you the myoma resection. So as you can see, I am working very slowly. Some people misunderstand my message and think I'm showing off working very fast and finish quickly. Not at all. Working very slowly but at a good vision like this, and you'll finish quickly. You don't have to work quickly or at speed to finish. No. Work slowly under vision and cut big pieces of the myoma, push them to one side and keep working on until this is the pedicle of the myoma, right? Okay, this is the myoma bed, you see? This is the myoma bed, and myoma converted into these pieces of meat. You can give it to your cat or to your dog. Very rarely you suffer an eventual event like this, bleeding, pumping vessel. At that moment, I know that my pressure is less than 100. So what you do is increase the fluid pressure to tamponate the vessel and go and touch. It will take 10 seconds. But if you keep at a low pressure of fluid, this pumping vessel will turn everything red. You will not find it. You will not reach the bleeder. Please, we have to be scientific. We have to obey the guidelines, but we have to be logic. The guidelines are not made to delete my mind, all right? So with all my respect to those who put a guideline that don't exceed a pressure of 80 or whatever, this is not accepted in a situation like this. Look, now you cannot see well. So when we increase the pressure, now pressure increase, you can see now well, and you can touch the bleeder. That's a James Bond movie, all right? Let me show it to you again. This is the bleeder. Initially pressure is low. Increase the pressure gradually. This will tamponate the vessel and you see the source of bleeding. And touch. So, my dear friends, I hope that I deliver my message to you. I hope that the time we spend together would bring to you some light, some new insights. Again, I have all the respect to the teachings that I learned since I started. But you have to respect your experience when you have an experience, all right? The great Hippocrates said, I learned from my experience and not from the book. Books to be respected, but if what in the book is not applicable, don't be stubborn. So again, I wish you good luck and safe practice. Again, this type of big procedures is not for the beginners. 80% of the work is within the hand of everybody, like a small polyp, very small myoma, less than 1.5 centimeter, short septum. You can do it with whatever equipment, scissors or with a resectoscope. It is very safe. But for the big pathology, you have to readjust the settings and what we learned. At last, thank you very much, everybody. I wish to be with you in Nigeria. I enjoyed the best time of my life. Best, lovely people, the most delicious food, wonderful landscapes and sightseeing. So I miss you very much. Take care of yourself, and I'm sure that soon we will meet. Thank you very much. Bye-bye.